Hey, this is Ron Broussard. Today we'll be talking about multi-systems trauma and trauma in special patient populations. So your geriatrics, pediatrics, pregnant patients, and also cognitively impaired patients. Now, with the involvement of multiple body systems in trauma, it makes management of the trauma patients more challenging. In a sense, there's more going on with these patients. While a majority of our trauma patients are, a single traumatic injury, they're not complicated traumas. We do have that rarity where we do have the multi-systems trauma patients. Now, uh, we do need to take special consideration when assessing and managing pediatrics, geriatrics, pregnant, and cognitively impaired trauma patients. The way that they compensate is going to be different. Some patients compensate better than others. Our pediatric patients are going to compensate well initially, and then their decompensation happens extremely fast. Whereas geriatric patients don't compensate as well initially for shock and go into more of a decompensated shock quicker. Now, we're going to go into each one of these a little bit more in detail. Now, when dealing with multi-systems trauma, a patient's considered to be multi-systems trauma when more than one major system is involved. So whether it be the cardiac and respiratory, neuro and respiratory, uh, ultimately we have multiple body systems that are involved. Usually it takes significant force in order to create these multi-system trauma. Now, with significant force, there is the risk for multiple injuries to multiple systems. Now, there's a high incidence of morbidity and mortality in patients with multi-systems trauma. Now, with a singular trauma, our body is able to compensate. But with multi-systems trauma, let's say we have a patient that has been shot multiple times, as an example, and they're hemorrhaging. Well, some of the things that we do in order to compensate, we'll vasoconstrict, try to increase blood pressure, but we'll also increase breathing in order to get more oxygen in to oxygenate the blood that we do have. Now, what if our patient's, shot in the leg and hemorrhaging, but then also shot in the chest and has a, tension pneumothorax developing? So now we have multi-system trauma, so we're affecting our patient's ability to even compensate for the one injury. Now, the risk of developing shock is higher with multi-systems trauma. Again, just because our ability to compensate has, been hampered. Now, the care for multi-system trauma patients ultimately depend on the system that's involved. All right, for like hemorrhaging, obviously we're going to want to control the bleed. For breathing issues, we're going to want to oxygenate and ensure, adequate ventilation of that patient. Now, for trauma patients in general, multi-systems trauma patients where you have shock, surgery is going to be definitive care. Okay, uh, you know, in trauma, a lot of times the basic life support is all that can be done in the field for these patients. Yes, there are advanced techniques, IV access, surgical airways, needle chest decompression. There are more things out there, but the place where this patient's going to recover is going to be in the hospital receiving surgery at a trauma center. Now, golden principles of pre-hospital multi-systems trauma care. Ultimately, of course, guys, ensure your safety. Okay, you cannot provide care if you become a victim yourself. Okay, making sure you have adequate resources on scene. All right, make sure you have fire department there to extricate your patient. Make sure you have advanced life support there, and then in order to provide those, higher levels of care like IVIO access, like needle chest decompression if needed. Okay, make sure you have those resources there available. Now, understanding kinematics. Now, that's just bodies in motion and understanding how in mechanisms certain injuries occur. So if we understand the mechanism of injury, we can then understand the injuries that we see on that patient, like a frontal impact from a vehicle impact. We understand that with bodies in motion, we are going to see injuries to the anterior aspect of the patient because the inertia of that accident is propelling the body forward from a front end collision. Now, we need to identify and manage live threats. Okay, that's, get your general impression. You walk up on scene, you're going to identify and manage those live threats as you find them. Okay, manage the airway while maintaining C-spine. And then support ventilation and oxygenation is a big part of it as well. We're going to control any external hemorrhage and treat for shock. Okay, perform a secondary assessment and obtain a medical history. Now, the thing with this is a rapid trauma assessment. Okay, it shouldn't take you any more than 2 minutes to complete a rapid head-to-toe assessment in order to find possible life threats that you may have skipped over from your primary assessment. Now, medical history, get a quick assessment of what you can find out, sample OPQRST type stuff, but you're not going to delay transport, okay? You're going to get that information en route if you can. Now, splint, skeletal injuries, and maintain spinal restriction if needed. Now, this is going to be another thing that's going to be done en route to the hospital, unless, of course, it's one of those critical fractures, like a pelvic fracture, bilateral femur fractures. Of course, you want to stabilize them before moving the patient, which could cause further harm and cause them to deteriorate, and then make transport decisions. Now, this is outside of just your, okay, this is a critical load and go patient. Okay, it's transport decisions are also going to be along the lines of where am I taking this patient to? If I have a multi-systems trauma patient and my closest hospital isn't a trauma center, I may just relocate that patient from one facility or from the street to the facility, and then they're going to have to do what they can to stabilize the patient and then transport that patient to the appropriate facility again. So we could be delaying definitive care if we take the patient to the wrong place. So make sure you're making good transport decisions, and if you have a multi-systems trauma, they should be going to a level 1 or level 2 trauma center in order to manage that patient effectively. Now, here are special patient populations. So pregnant patients, we do have some anatomical and physiological changes that occur in pregnancy that we need to be aware of when we're dealing with a traumatic injury to that population. Now, it is difficult to assess the fetus. I understand you're not going to be attaching monitors, you're not going to have ultrasound out there to get fetal heart tones, anything like that. So your focus is going to be primarily on the mom. Treating the mom aggressively is going to treat the fetus. Now, blood volume is increased by up to 50% in late pregnancy. I think your textbook says something a little less, but then chapter 37 does hit on, 50%. All the books that I've read about pregnancy roughly have blood volume increasing 50%. Now, that is a significant increase in blood volume. The one thing that we don't necessarily see, though, is while we do see an increase in volume, we don't see a one-to-one increase in red blood cells. So we can still have a relative anemia to how much the blood volume is increasing in that patient, if that makes sense. Now, heart rate increases by 10 to 15 beats per minute in the third trimester, and then the uterus becomes highly vascular. Now, uterus is highly vascular. Okay, it's getting nutrients. Now, where the placenta attaches, that is pulling the nutrients from mom, okay, down then into the fetus itself. Now, the diaphragm becomes elevated to make room for the baby. Now, pain perception in the abdomen is altered. Now, in a sense, you are stretching nerve fibers, which could ultimately affect the perception of that pain due to the stretch of tissue. We do see a decrease in gastric motility and increased risk of vomiting. All right, I'm sure if a woman's been pregnant, you could probably relate to this, the morning sickness. Now, it's just things in the abdomen aren't working as they should, mainly due to hormones and HCG, so human chorionic gonadotropin, those hormones increasing, which causes that nausea. Now, the uterus and bladder are at greater risk of injury. Now, the uterus, is growing, and it's becoming more susceptible to injury due to displacement out of the pelvic girdle. Okay, so it's growing into the abdominal cavity. Same thing with the bladder. When the woman is pregnant and the uterus grows, the bladder gets displaced superiorly and anteriorly, so up and forward, pushing it up out of that pelvic girdle, making it more prone to trauma. Now, assessment considerations for these patients. Now, the more severe the injury is to the mother, the greater the chance of fetal injury. The sad thing is when we have these traumatic incident, okay, and mom's going into shock. All right, now if we know we're losing blood volume, we vasoconstrict. Well, one of the places we vasoconstrict to shunt blood away from is going to be that fetus. All right, it's going to be to shunt blood away from the fetus to keep mom alive. Now, fetal death rates are 9 times higher than maternal death rates following trauma. All right, so in a sense, mom's body is trying to keep her alive more so than the baby, and that's why aggressive treatment of the mom will result in better outcomes for the fetus. Now, the most common problem caused by maternal trauma is uterine contractions that may progress into labor. Now, this is a big concern because if we have that traumatic incident that occurs and mom's starting to shunt blood away from that fetus, well, one of the responses is going to be, hey, let's uterine contractions, let's get this fetus out of me, in a sense, because it's taking life from me. So it's going to be to expel the fetus. And the issue becomes like if that baby is going to be premature and not going to be viable, on its own without the life support from mom. Now, abruptio placentae is a premature separation of the placenta from the uterine wall. Now, you have complete abruption and partial abruptions. Understand if you have a complete abruption where the placenta has completely torn away from the uterine wall, there is there's significant hemorrhage in the mother, okay, but the maternal or the fetal death rate is 100%. Okay, so if you have a complete abruption, you have a 100% fetal loss, whereas a partial, I believe, is right around 60%. Now, there's not going to be a way for us to determine if it's a partial or a complete abruption, but understand that the survivability of the baby is very, very low. Now, with abruptio placentae versus placenta previa, hallmark sign of placental abruption is going to be a sharp or tearing abdominal pain associated with vaginal bleeding, whereas placenta previa is going to be no abdominal pain, but you do have vaginal bleeding that's occurring. Color of the blood doesn't matter so much. It can be dark, it can be bright red. It's just you have vaginal bleeding with associated abdominal pain. Now, fetal and maternal outcomes from motor vehicle collisions are more favorable when the mother wears a seatbelt. Mother is twice as likely to go into preterm labor, to deliver a stillborn, or to lose that fetus when a seatbelt is not worn versus when a seatbelt is worn. Now, uterine rupture may occur as a result of motor vehicle trauma. Now, a lot of examples of motor vehicle trauma, it's because motor vehicle collisions is going to be the leading mechanism of injury in our pregnant patients. Okay. Now, with uterine trauma, or uterine rupture, it can result in maternal and fetal death. Now, that is simply where the uterus is ruptured. The uterus is that smooth muscle that's housing that fetus as it grows and develops. Well, if that ruptures and tears, the baby actually goes into the abdominal cavity. And in order to have a good, healthy delivery process, you need the uterus to be intact. And if it's not, you're not going to have good, adequate contractions to deliver that baby. Now, with these patients, fetal distress can be caused by hypoxia or hypovolemia. Now, with that, just if the baby is not getting nutrients in utero, it causes fetal distress. Understand now, signs and symptoms of shock in the patient, like the pregnant patient, can be masked. Why? Because mom has increased volume. Okay, mom has an increased heart rate. Mom's respiratory rate is normally increased. Now, when we're assessing this patient, it could be hard for us to, it's like, hey, mom looks like she's doing okay, however, she's doing okay because she's shunting blood away from that fetus. Okay, that's one reason why we give pregnant patients high flow oxygen. I know we've talked about, it's like, be careful with oxygenation of your patient, with pregnancy patients and multi-systems trauma and pregnant patients, we're going to go more high flow O2 regardless of SpO2 reading. Now, attempt resuscitation of a pulseless pregnant trauma patient according to protocol. In a sense, you working that baby, or not the baby, the mom, you providing CPR is going to be working to keep the fetus alive. There have been cases where, mom may have lost her life, but CPR done does save the baby. All right. Now, when managing pregnant patients, if we do have to use, spine immobilization and completely immobilize that patient, we do want to take great care when laying them flat. We can cause a condition called supine hypotensive syndrome. That is where the weight of the fetus itself puts pressure on the inferior vena cava, therefore decreases blood return to the heart, ultimately decreasing preload and cardiac output, which then decrease the blood pressure of the patient. Now, what we can do to prevent that is simply tilt the board a little to the left, pat underneath the patient, and then that way it will help displace the fetus off of the inferior vena cava and increase our blood return to the heart. Now, airway ventilation and oxygenation are extremely critical. I know I talked about it a little bit already. High flow oxygen to these patients. Be ready to deal with vomiting in these patients too, so just have suction ready. Now, we're going to assist ventilation if clinically indicated, so if breathing becomes inadequate. High flow O2, 15 liters, not a breather mask. All right. And now understand that the fetus can become severely hypoxic before the mom shows any signs of hypoxia. All right. So if I go up and I'm starting to assess the mother and I have the pulse ox on the patient and she's at 94%, well, what is the baby getting? So if I can throw that mom on a non-breather mask, because she has the mechanism that supports it, throw her on the non-breather mask and oxygenate her, that just increases the likelihood that the baby's getting adequate oxygenation. All right, circulation, check for major bleeding and control major bleeding. All right, well, we're never going to pack anything into the vagina if we have any vaginal bleeding, but we will use like maternity pads or gauze pads to put external pressure, okay, to absorb vaginal bleeding. We're never going to pack anything into the vagina though. And then, of course, anticipate and treat for shock. Again, high flow O2, lay the patient in a supine position, tilting a little to the left to prevent supine hypotensive syndrome. Cover the patient, keep them warm. I will say that's probably one of the biggest things that I've seen, that we're guilty of in EMS is treating hypothermia, because we're teaching, trauma naked and cut everything off and expose and assess the patient. But do we ever recover them back up again, So make sure you're keeping those patients warm. Now, consider ALS intercept or air medical transport for major traumas involving pregnant patients, and then anticipate the need for additional resources if delivery is imminent, i.e. you see crowning, mom has that urge to push. Guess what? You went from having now one patient to two patients, so make sure you have the resources to deal with two patients. All right, so click on the intervention that is required to prevent supine hypotensive syndrome when managing a pregnant trauma patient. So A, fill all voids beneath the patient's back with padding when applying a long backboard. B, administer oxygen at 15 liters per minute by non-breather mask for all pregnant trauma patients. Okay. C, tilt the long backboard on the patient's left once straps are applied. And then D, transport the patient in a semi-fallish position with the knees and hips flexed. All right. So specifically asking about preventing supine hypotensive syndrome. Okay. So what we can do to prevent this is tilt the long backboard to the patient's left once straps are applied. All right. So tilt the board to the left. Okay. That displaces the fetus. All right. And hopefully helps improve blood return to the heart. And if you're thinking, well, hey, apply oxygen, well, that's great. Yeah, we want to apply 15 liters for our pregnant trauma patients. However, that does nothing for supine hypotensive syndrome. Now, pediatric patients. Now, pediatric patients' mechanisms include drowning, burns, falls, penetrating trauma, motor vehicle collisions, and pedestrian versus vehicle collisions. Sad thing is, a large amount of the trauma, not a large amount, but it's caused by abuse. 25 to 35% of pediatric traumas are caused by abuse. So if you suspect abuse, make sure you're reporting that. Oftentimes these patients are abused, and if we can identify it early, that could prevent something more catastrophic down the road. Okay, so 25 to 35% of our trauma patients in pediatric populations are abused, and that's extremely sad. And if we can reduce that, we can help these patients. That'll be, our biggest goal. All right. Now, with some of the anatomic and physiological considerations in the pediatric trauma patient, understand that they're small. Therefore, traumatic forces are widely distributed through their bodies. Pediatric patients, heavy heads and weak neck muscles, especially infants and toddlers. If you ever seen like a little 2-year-old who's just getting up on their little baby legs and starting to move around, head goes forward and their head's kind of all wobbly. They're building those muscles up. Now, if you have an infant or toddler and they're involved in a motor vehicle collision, in a sense, there's more weight in the head, neck's not as supportive, so you can get injury to the spinal cord. And the thing with kids too is their bones have more collagen in them, so you don't see the fractures as much, and so they can go in for an x-ray and have a cord injury but have absolutely no injuries to the vertebrae themselves. Now, with this, infants and children have greater chest wall flexibility than that of adults. All right, so again, when you're assessing those patients, they have more flexibility, so there's less likely to be, like that bone-on-bone grinding, that instability when you're palpating the chest. However, they can still have things like pulmonary cardiac contusions or damage to the underlying organs. All right, children are frequently victims of major and minor trauma. The leading cause of trauma in your pediatric population is going to be falls. But again, a high number, 25 to 35%, is going to be abuse related. Now, some of the assessment considerations in the pediatric trauma patient. Now, big thing that we use is the pediatric assessment triangle. Okay, now this is going to be part of our general impression. As we're walking in on this patient, as we're walking up to the scene, what do we see? And we use the pediatric assessment triangle to, assess that patient based off of our initial impression. Okay, with this, we look at appearance, work of breathing, and circulation to skin. All right, with appearance, okay, we're not necessarily looking at color here. We're looking at their tone, muscle tone. Like are they moving vigorously? Okay, or are they all limp? Are they weak appearing? Are they irritable and crying a lot? Okay, are they consolable? Is mom able to calm them down and work them down? All right, what's their cry like? I know we're kind of getting into work of breathing a little bit, but do we have a good loud strong cry, or do we have a weak cry? Okay, work of breathing. Do we see nasal flaring? Do we see accessory muscle use, retractions? Okay, do we see grunting that's occurring in that child? And then circulation of skin, we're looking at, of course, the coloration of the child. So, are they pale? Are they flushed? Do they have cyanosis on them? All right, so that's what we're using as our general impression when we walk up on these patients. And we're doing that without touching the child, because if we do start to elicit assessment stimuli on them, we can, of course, get them to start crying, especially if we start assessing the chest and there's trauma to the chest. If I start touching that, child's going to start crying. Is that going to change the breathing pattern? You bet it is. So understand it's kind of our general impression of the patient, pediatric assessment triangle, as we walk into the scene. What do we see? Now, subtle changes in the heart rate, blood pressure, skin perfusion may indicate cardiorespiratory failure. Understand these kids will compensate very well. They'll compensate, everything will look great, and then they'll fall off. In a sense, when they get exhausted, when their body gets exhausted from compensating, it stops, and that decompensatory period is very short. Okay, recognize that a slow heart rate may be an indicator of hypoxia, especially early on, especially for your infants. If you see bradycardia in those patients, that's letting you know there's some hypoxia and that patient needs oxygen. we assess brachial pulses, all right, for our infants, brachial pulses versus, a carotid pulse. Reason for that is their tracheas are more pliable in infancy, and we don't want to cause any issues with the airway. We're also going to avoid getting blood pressures on patients younger than 3. Okay, so we will only get blood pressures on patients 3 years of age or older. Okay. Now, if we do need to provide spine motion restriction to these patients, because little kids, they have larger heads and larger occipital regions in comparison to their body, we may need to pad underneath their shoulders in order to put that airway in a good neutral position to promote patency. So if you ever lay a child flat, like a little baby flat on their back, what ends up happening is they go to a chin to chest type position, which can occlude the airway a little bit. So we'll pad underneath the shoulders to put that airway in a nice neutral position to keep it open. And then we'll open the airway and assess for any possible obstructions. Things like gurgling, which can indicate need for suction, or stridor, which can indicate swelling or inflammation in the upper airway. Okay, assess circulation and control any bleeding. Now, little kids aren't going to have a lot of volume to lose to begin with, so make sure you're controlling hemorrhage, okay, as soon as you can. Manage hypovolemia and shock. Shock management. Patient goes in a flat supine position. High flow oxygen. Keep them warm. Control any external hemorrhage. Keep them warm is the big thing. Prevent hypothermia. We've already talked about it with the pregnancy patients. Remember, that's the thing we're guilty of. Cover them. Cover them up. Keep the patient warm, especially those little kids and the babies. Okay, they have more surface area than they do mass, so they cool down extremely fast. Okay, they can cool down fast and they can also heat up fast, but in a sense, keep them covered. Transport to the appropriate facility, i.e., if I have a trauma patient and they're a pediatric patient, I'll take them to the pediatric trauma center versus just a regular trauma center. There are lots of options where you guys are at in Southern California, where you have, I have county that's a level 2 pediatric trauma center up, and I have another one that's a level 2 trauma center, and it's the same distance either way I go. They're in opposite directions. Where am I going to go? If I have that pediatric, take them to the pediatric trauma center. Now, geriatric populations. Geriatrics, the risk of death and significant injury is greater than for younger patients. Number of physiological changes predispose the elderly patients to injuries, i.e. like osteoporosis. Okay, bones lose their density, become more prone to fracture. Falls are going to be the most common cause of injury, and then many falls are the result of medical conditions. Maybe they go hypoglycemic. Maybe their blood pressure drops too fast. Whatever it may be. Maybe they have AFib and they have a syncopal episode. Okay, so those falls are a result of a medical condition. Now, with some of the anatomical and physiological changes that occur, we see pulmonary, cardiovascular, neurologic, musculoskeletal system changes with aging. Okay, pulmonary system. Okay, gas exchange becomes less effective, so we see higher respiratory rates. Okay, normally respiratory rate might be 16 in a healthy adult. Well, your geriatric patient might breathe around 20, 22, 24 times a minute in order to have good oxygenation. Cough reflex, okay, it's a little bit weaker. Cardiovascular system doesn't function as well. We'll see higher systolic pressures, although we don't necessarily see a great improvement in cardiac output. Neurological changes. They have less kinesthetic awareness, in a sense, where their body is in space as they're moving. Geriatric patients, especially like Alzheimer's, dementia, we see more of a shuffling of their feet instead of a nice, good stride. Musculoskeletal system, we talked about a little bit. We see loss of density in the bones that make them more prone to fracture. Now, these changes make injury more likely and make it harder for elderly patients to then compensate when the injury occurs. Now, some of the assessment considerations. Understand that they're probably going to have pre-existing medical conditions and medications that affect the patient's outcome. If you think about some of our compensatory mechanisms, if we fall and we, have, a broken pelvis and we have internal bleeding, What is our way to compensate for hypovolemic shock, for bleeding? Well, it's to increase our heart rate to increase our blood pressure, right? Well, what if this patient has a history of high blood pressure and now they're taking a beta blocker medication that decreases heart rate and contractility to maintain a blood pressure, and they're also taking an ACE inhibitor to keep their blood pressure down. And now our body's mechanisms in order to compensate for shock are then affected because they can't increase heart rate. They can't increase it effectively. They can't vasoconstrict well enough because these medications that they're taking. Altered mental status is a significant finding in all of our patients. Okay. Now we need to be alert to airway obstruction from dentures. So if we have dentures in place and they're free floating, they're not secured, they need to come out. Now, if they have dentures and they are secured, we want to keep them in place because they give us some structure if we need to ventilate that patient. Now, with management considerations, we want to pad if we're using a backboard. Okay, if we're putting a patient flat, we want to pad those voids. The last thing we want to do is, if we have a patient who has kyphosis and they have that, hunchback appearance and they're hunched over at the thoracic spine, the last thing we want to do is straighten them out on a backboard. So we're going to pad underneath the head. If we have excessive lordosis that sway back in the lower back, we're going to pad underneath in order to keep the patient somewhat comfortable. Okay, maintain a clear airway, be prepared to suction, support ventilations as clinically indicated, so we're making sure we're oxygenating the patient effectively. Okay, now with trauma in the cognitively impaired patients. Now, cognitively impaired patients, we're covering a wide range of conditions here. Okay, this can be, your geriatric patient who has Alzheimer's. This can be your 14-year-old patient that has Down syndrome. We're covering a wide range of patients. Understand that cognitively impaired patients are more prone to trauma. Now, cognitive impairment can affect assessment and management, especially if the patient's not able to communicate with you. All right, if the patient's not able to tell you that they're hurting, that they're in pain, they just make noises. Okay, that can make assessment and treatment of that patient extremely challenging. Okay, so when you're assessing a patient, ultimately you want to treat that patient with dignity and respect. Okay, don't just assume that they have problems and they can't communicate with you. You can have patients who are very high functioning. I've seen it in the hospital. There's a condition called sundowners where a patient will be, alert and oriented with you during the day. And then as the day progresses and it gets into nighttime, that's when their cognitive decline really starts to show and then deteriorate. They become confused, they may be combative. But during the day, they were just fine. So never just assume that these patients can't communicate with you. So if we can, we'll try to assess the patient. Okay, we'll try to get information with the patient, and then use the caregiver in order to fill the voids. All right. Now, who could better tell you about where pain is at than the patient? Is the caregiver going to be like, hey, with one finger, point to where the pain's at? No, because they're not the one necessarily feeling the pain. They just know that they're in pain. Now, if the patient can talk to you, all right, so we're going to direct those, history of present illness questions to the patient. Hey, where's your pain? Point to me where it's at. Keep it at levels that they can understand. Now, use the caregiver then to fill the voids. Things like past pertinent medical history, any medications that they're taking, last oral intake. Fill that stuff in with the caregiver. And then, of course, if the patient has severe impairment, then yes, you need to go to the caregiver for a majority of the stuff. But you're not going to just act like the patient isn't there. So, anatomical and physiological considerations. Now, understand that these conditions could cause issues with airway management, such as patients with Down syndrome typically have larger tongues in proportion to their mouth, more likely to cause an airway problem for us. Okay? Patients with severe dementia, Alzheimer's, eventually that disease process starts to affect areas of their brainstem that regulate breathing, regulate blood pressure. That can really affect our patient's ability to deal with their condition. Now, many patients have sensory loss related to aging and disease. Things like a patient with a stroke, okay, may have hemiparesis, where they're paralyzed, extremely weak on one side of their body. Geriatric patients, in general, we see a decreased sensation to pain, just due to neuropathy. So understand these patients may perceive things a little different because of their condition or age even. Now, with assessment considerations in the cognitively impaired patient, history and consent are difficult to obtain. Now notice here, first attempt to get information should be from the patient, okay? Then we rely on others for information if needed. Now the patient may be confused, upset, and uncooperative. That's okay. However, try to get a baseline for the patient. That's great to deal with the caregivers. It's like, all right, well, is this how they normally are? What is their baseline? And then how are things going from the baseline? If normally they don't know what year it is, if normally they don't know where they're at, and they're still at the baseline, that's telling me something versus, well, normally this patient knows where they are. Normally they can tell me, what year it is, and normally they're very cooperative and friendly. And now they're all combative. Well, they could be combative because they're hypoxic. They could be combative because they have a bleed somewhere internally that's causing hypovolemia, causing their blood pressure to go down, causing hypoxia in the cells, all right, which is causing this combativeness. So understand if we can get a baseline for this patient, that could help us understand what's going on and how they're deteriorating. Now, pain perception may be altered. Gain information through the trauma assessment. Okay, so that's where we're doing that head-to-toe assessment. We're never just going to assume that, oh, they are cognitively impaired, that's why they're like this. Okay, so do a good head-to-toe. Now, in the head, do a good neuro assessment. All right, assess the pupils. Look for raccoon eyes. Look for battle signs. Okay, look for signs that there's head trauma there. Okay, maintain a high index of suspicion that impairment is a result from injury rather than the condition itself. All right, don't just assume that, oh, they have Alzheimer's, that's why they're like this. Oh, they have Down syndrome, that's why they're like this. Don't just assume, make sure you're assessing the patient. Okay, now involve the caregivers to increase cooperation. They can be extremely helpful to you. Not only that, but they can help the patient feel more comfortable, which makes it easier for you to then assess the patient. You're new to them. Okay, patients who have, like things like autism or Down syndrome, like, their routine. Well, you're new to that routine. All right, so they might not respond to you very well. However, they may respond very well to the caregiver. So if you need to assess an area, they may not want you touching them. They may not want you lifting their shirt, okay, but they may be a little bit more comfortable with the caregiver. So incorporate them into the assessment. Now, err on the side of caution and always treat these patients as if they have a head injury, especially if you don't have a good baseline for the patient. Okay, so emergency medical care for these patients. Now, always use standard precautions. Use the appropriate BSI for your patient based off of the condition that they have. Now, generally, third trimester pregnancy, if we're backboarding a patient that's in our third trimester, we're going to tilt them to the left side to prevent supine hypotensive syndrome. Children younger than 8, we're going to be patting underneath the shoulders to maintain a good neutral airway. And then for elderly patients, we're going to be patting the void. So whether it's they're kyphotic or they have lordosis, we're going to be patting the voids because we're not trying to flatten them out on our backboard. Now, we're going to maintain adequate airway. All right, so using a draw thrust maneuver, in the sense we're dealing with trauma patients, so we want to protect the spine. Be prepared to suction and administer oxygen to these patients. Monitor the airway, breathing, pulse, and mental status for deterioration. Now, very important to get a good baseline mental status for the patient so you can identify if they're getting worse or getting better, especially if they're one of the cognitively impaired patients. Like that cognitively impaired patient was a little confused and not very combative, and now they're very combative, and now they don't answer any of your questions correctly. That's a deterioration mentally for them. Now, control any bleeding, treat for shock, identify and treat other injuries. Think along the lines of those critical fractures. Okay, we're talking about trauma still, so pelvic fractures, bilateral femur fractures. All right. Transport immediately. Notify the receiving facility of what you have. Give them a good report of the patient's condition and their history. And then consider requesting ALS. Reassess vital signs every 5 minutes. We're talking about unstable multi-systems trauma patients here. All right. So, lesson summary: suspect multi-system trauma in any patient who has been subjected to a significant external force. Utilize the golden principles of trauma care to manage patients with multi-systems trauma. Make sure your scene is safe, control life-threatening injuries, maintain adequate airway, breathing, and circulation. All right, understand the kinematics of trauma, so how bodies move in trauma. Limit scene time. All right, stuff like that. Where remember, for those critically injured trauma patients, we're not going to want to be on scene for any more than 10 minutes. Okay, special patient populations require additional assessment and management considerations. We talked about those, okay? Understand, like a pregnant patient. Well, the best way to treat that baby is by treating mom, okay? Your geriatric patients, they can have underlying health conditions that contribute to their trauma and why they're not maybe compensating well. And now, as an EMT, we need to incorporate knowledge of these special patient populations and then incorporate that into our care that we deliver to those patients. All right, and that concludes this period of instruction. Thank you.